All right, guys, welcome back here. Today we will be talking about CRRT and kind of some of the nursing considerations and just kind of going through this and explaining this for all the ICU nurses out there. Okay, so first thing we'll talk about is just what is CRRT? Okay, so CRRT stands for Continuous Renal Replacement Therapy. Continuous renal replacement therapy. Okay, so CRT is a form of dialysis that is typically used for patients who are too unstable to undergo traditional hemodialysis. This way, you'll see a lot of your critically ill patients, so your patients in the ICU who maybe their blood pressure or fluid status, they're not able to tolerate those large fluid shifts that occur with standard hemodialysis. So CRT is a slower and a continuous form of that kind of minimizes some of that fluid shift and those hemodynamics, so keep them a little more stable. So that's why you'll see this with a lot of your very critically ill patients. There are several different modes of CRT. Today and on my unit, we typically use CVVHD. So this is continuous venous hemodialysis. This is the mode that we typically use on my unit, so we will focus on this today. I do know there are a couple other modes. There's SCUF as well as sometimes we use SLED overnight. But for the most part, we are using CVVHD, so that's what we'll kind of focus on today. So the next thing we'll talk about here is just what are some of the indications for CRT. So as I mentioned earlier, the first and probably one of the most common indications is just that these patients who are typically hemodialysis patients who are too unstable to tolerate traditional HD, too unstable. And then other things here would be to correct electrolyte imbalances. Specifically, you're going to be probably looking at patients that may be very hyperkalemic. These patients may have a potassium level that's 5.7, maybe getting around 6, and that stuff. Maybe they're not producing urine and they need to clear this potassium out. So that is another indication there. You'll see it for patients. They could be chronic kidney failure patients, or you could see it for patients with acute kidney injury. So for this, you'll see like elevated creatinine, elevated BUN, and decreased, or maybe they're not producing any urine at all. Another thing can be used for just the removal of toxins / waste, so just kind of cleansing the blood there as well. Next thing we'll go to here is we'll just talk about how it works. Okay, so CRT works through a principle called diffusion. Diffusion is the movement of solutes from a place of high concentration to a place of low concentration. So we'll explain this here just a second. So I'll just write this real quick. Diffusion equals, this is the movement of solutes / particles from an area of high concentration to low concentration. So how this correlates with CRT. So here your movement of solutes / particles. So this could be things like your electrolytes. So this may be like your potassium. And then from an area of high concentration, so in this case, your area of high concentration is going to be your blood, to low concentration, this is going to be your dialysate fluid. And I should say this is through a semi-permeable membrane. I just feel like whatever, membrane. And in this case, your semi-permeable membrane is going to be your CRRT filter. Okay, so we'll break this down a little bit here. So how this works, so let's say your patient comes in and let's say they have a potassium of, let's say 5.9. Okay, so that's the potassium that's in their blood, right? So that's the area of high concentration. So potassium 5.9 in the blood. So blood is the area of high concentration. To an area of low concentration, this is your dialysate. So then your dialysate bags have specific concentrations, and you'll check it with your order. But let's just say it may be like 4K, 3 cal is a common dialysate concentration. So as you see here, this potassium is lower than this, so it's moved from an area of high concentration, so from the blood, to an area of low concentration. The potassium's lower in the dialysate, so to the dialysate fluid through a semi-permeable membrane, and that semi-permeable membrane is your CRRT filter. Next thing we'll kind of talk about here is just kind of the machine and some of the kind of things to look for as far as nursing considerations as well. So my facility, we use Next Stage is the CRT machine we use. This could be different for you if your facility uses a different CRT machine, but we'll kind of just go over some of this stuff anyways. I think Next Stage is pretty popular, so hopefully this makes sense and it's similar for you. So on your machine, you will have typically on the Next Stage machine, there's 3 on your console. You'll see 3 sets of arrows. You'll see one with a green set of arrows here. You will see a yellow set of arrows. We'll just draw these out real quick. And then you also see a red set of arrows as well. Okay. So the green set of arrows, this is going to be the rate of the dialysate fluid. The yellow is going to be the rate of fluid removal. And the red is going to be the blood pump rate. So the blood pump rate is just how fast the blood is moving through the machine. The green arrows, the rate of the dialysate fluid, is pretty self-explanatory. So how fast the dialysate is flowing as well. And then yellow is the rate of fluid removal, so how much you are pulling and removing from the blood. So you'll typically see something here like this may be, your order may say 2,500 mLs an hour for the dialysate fluid. So this is actually measured in liters though. So it'll be on the machine, you'll see something like 2.5. Your rate of fluid removal, this is adjustable. So this we'll talk about here in a little bit as far as you'll need to do some mental math to calculate this. Let's just put 200. And then the red is your blood pump rate. This is typically set rate by an order from your nephrologist, okay? So this is something, it's normally between maybe 200 and 300, so we'll go with 300 here. So as far as calculating this rate here, so when you have CRT, it's very important that you are on top of your I's and O's, and you needing to calculate, how much is going in every hour. So typically you will get you will get an order that may say, let's say your goal is even to negative 50 mLs an hour. So let's write this out over here. Example, goal is even to negative 50 mLs an hour, right? So it's very important you're going to calculate all the drips that your patient is on and how many mLs an hour they are running. That goes in, as well as something like tube feeds as well, if they're having NG tube with receiving feeds. So anything going in has to be accounted for. So let's say they're on, for this example, we'll make it easy. Let's say they are on a normal saline drip, and it's running at, we'll just say 100 mLs an hour. Maybe they're also on some Levo, and let's say this is running, we'll say this is running at 10 mLs an hour. And that's the only two drips are on. They're not on any tube feeds, anything like that. So for here, total intake is 110 mLs an hour. Okay, so now you know your intake's 110 mLs an hour. So if your goal is even to negative 50, this is where you come and you set this rate here. So all you do, so if your goal is even and you want to be exactly even, then this is just, you're going to set this to whatever the intake is. So in this example, if you want it to be even, they're getting 110 mLs in per hour, you're going to pull 110 mLs out an hour. Or negative 50, so you want to remove 50 more than they're getting in. So they're getting in 110 mLs an hour, so if you want to pull 50 more, you could set this at 160 mLs an hour. A lot of nurses you will see may, try to pull more to kind of get ahead, because as you get into your shift, you will notice, you have unexpected infusions, right? You're going to have to replace electrolytes or give blood, and all that stuff can kind of throw your total I's and O's out of whack. So just check the policy in your hospital, make sure that see if that's allowed or not. If it is, and that's something you're comfortable doing, and some nurses will kind of pull more initially and get ahead. But a lot of nurses just kind of stick to it. I tend to just stick to the order, right? So if it's negative 50 mLs an hour, then that's the most as I'll pull on. If I kind of get behind, then that's just sometimes that's just kind of part of it, and there's not much you can do about it, right? Other things with the machine, let's erase some of this stuff up here. So machine considerations as well. Actually, we'll just go straight into the nursing considerations. 1 second here. Okay, so some nursing considerations for CRT. You definitely going to want to be checking the dialysate bag level. You do not want that running dry. That can be a pain just to kind of replace and have to reprime some of that stuff there. So you're always checking your bags. You're checking your lines. Make sure they're not kinked, or make sure they're not pulling You always want to have, slack on those lines, so not pulling on the patient's HD catheter. You're checking for air, and the system will alarm you, but sometimes you can catch it beforehand. Checking for air in the lines, maybe air in the you'll see in the fluid warmer bag. You can always remove that as well. Other things you're going to want to know is, is the provider okay with pulling more versus, having to add pressors. So a lot of times as you remove more fluid, your patient's blood pressure will decrease. So that's just something you're going to have to kind of clarify and communicate with your team. Are they okay with pulling more if you have to go up on pressors or add pressors, or would they rather avoid vasopressors and just, pull what you can, but do not, pull to the point where the patient is hypotensive. So that's something to definitely clarify with the team. Another thing with the CRT is always going to want to know, you have to know how to rinse back. This is very important here. So say your CRT machine clots, or you have air and you're unable to, the machine's unable to keep running. You typically only have a few minutes before that blood clots, and then it's unable to get back to the patient. So you're always going to know how to rinse back. This prevents the patient from losing blood. The amount of blood that's in the circuit, I think, kind of varies. I think with the next stage, it's normally like around 191 to 210, somewhere in there as far as mLs of blood. So especially important if you have a patient who maybe their hemoglobin and their hematocrit or the platelets are already pretty low. You don't want to be losing any more blood, right? So when you rinse back, it's important to know. So with this, you'll have a red line and a blue line going to the patient's HD catheter. So the red line is just pulling away your arterial line, right? You're pulling away from the patient. Whereas your blue line, this is returning blood to the patient. So when you rinse back, what you'll do is, you'll typically stop the machine. You're going to disconnect the red line from the patient's HD catheter, and you will connect this red line to the saline bag, the saline port. On the next stage model, it's just a white cap coming off the saline bag, and then there's a button you can press that will rinse back. It will rinse the saline back, and that will return all the blood in the circuit and returns it through the blue line, so the patient doesn't lose all the blood. And then from there, you'll have to get a new circuit, get a new filter, and set everything back up. But important to know how to do this, because typically you don't have much time to do that. Other thing to know or to look for is definitely your waistline. So typically your waistline will be running into the toilet, typically in the room. It's important to know that the line must be above water level. So you don't want the end of the line submerged in water. This will just cause pressure, and then it will back up into your machine. Your machine will not run correctly. So it's always important to check that. You're checking all your connections, making sure everything is tight as well. Other nursing considerations here, definitely things to monitor as far as on the patient. Probably the biggest thing is hemodynamics, specifically your blood pressure. So it's kind of like we talked about earlier. Typically, the more you pull, the lower the patient's blood pressure will go once you reach a certain level. Some patients tolerate it pretty well, and it's no big deal. But, if your patient was okay, maybe they're a little soft, then you're trying to pull more to reach your goal. And now, you notice your patient's MAP is, 58, 59 or 60-ish. That's where you need to know or kind of be on the same page with the provider and the nephrologist as far as, are they wanting to pull? Maybe it's very important to pull, or they, add pressors, or they want to back off on the pull so they can avoid the use of vasopressors. So just clarify that beforehand and make sure everyone's on the same page there. Other thing that's very important is going to be checking and replacing your electrolytes. So obviously, we're expecting a lot of times with patients, maybe their potassium to come down. You should definitely have PRN orders that have guidelines for, when to replace and how much to replace. Typically, you'll be checking these probably around every 4 hours or so when they're on CRT. So electrolyte replacement is a big component of CRT because, you don't want them to get too low because that can also cause difficulties and some other issues. So you're probably checking potassium, you're probably a full BMP, your mag, your ionized calcium, and your phosphorus as well. And those are also all very common to need to replace during CRT. And monitor for, things that happen when your electrolytes get out of whack, right? So arrhythmias, things of that nature, anything you see like that, little short runs of VTAC, any type, that could always be a good sign that, you need to check lights and some stuff may need to be replenished. And then another thing is just, obviously your overall fluid status of the patient. So this can, like we talked about here, and this big one I miss is just fluid removal for patients that are fluid overloaded. So, you're trying to see, how much fluid needs to be pulled. And remember your goal, you'll have your orders, check your orders, knowing, how much to pull, if it's too much or too little, just kind of the overall, patient picture. If you're having issues with the CRT machine, or maybe you're not able to pull because their blood pressure is too low, it's definitely something that you need to notify the team of and make sure everyone is aware. And then obviously, you're not going to want to be pulling too much because most of the patients probably will not be able to tolerate that. So just kind of knowing why your patient's there, why are they needing this CRT, and then kind of the overall goal. That's obviously very important. Okay, so that kind of covers just the basics there of CRT. We kind of covered what it is, indications for it, some nursing considerations, and the machine and kind of how it's set up and some of the settings on there. If you have any questions, please let me know. If you learned anything from this video, I'd greatly appreciate if you would like and subscribe to the channel. That would be much appreciated and would help me a lot. All right, y'all let me know if you have any questions. I appreciate you watching.